everybody for giving me this opportunity. Really just to share with you some thoughts on what we see the opportunities are for consolidation, how we might consolidate pathology in England. So I'll start off with a number that we're all probably too familiar with, 29, number of pathology clusters or networks that's been identified for England. I promise this is not the number I'm going to be talking about today. I'll spend a few minutes on it. I think this is a way that pathology can be consolidated. I think the way that this model was built was really by trying to understand where the majority of work is currently being delivered. So of the, I think, top 25 providers of pathology account for about 40% of the costs and about 40% of the volume that's currently being delivered. And even though this is a model for how pathology can be delivered, it definitely doesn't tell us how to get there. I think the way that we take it from where we are today, where we're currently delivering pathology across 105 service providers, to an opportunity where there's 29 or fewer, that would need different ways and different approaches, many of what we've heard about today. So the next number, that's according to our latest NHSI data, the number of consultants and other medical staff that's working within pathology. So it accounts for about 10% of our total pathology FTE complement. The reason I've got this up here is because we have to remember that we can't leave the consultants behind. The relationship that the UK or English consultants have with the laboratory and with the rest of the hospital is quite different from what we see elsewhere. A lot of the private markets where I work and where I've worked in the past is we see the pathologist or the consultant being the business owner. So they are primarily responsible for selling the value of the service to the other clinicians. In the UK, they are much more part of the clinical team. They're much more part of the patient care team. And I think this is one of the key reasons why warehouse laboratories struggle in the UK. Because what's happening, you're taking a key group of staff that's standing with one foot in the lab, one foot in the hospital, and you're pulling the lab out from under them. Yes, there's the option to follow the lab, but it then breaks the other critical link. So I think any model for consolidation in England has to consider this link, has to consider how we work more closely with a consultant. The Vipath example clearly showed us there's the need for operational management that needs to be shared with clinical management. Another number why I think warehouse laboratories that purely focus on the high volume blood sciences and routine work would struggle to be successful in the UK, or have struggled to be successful in the UK, is the amount of non-throughput related activities we see in smaller specialist laboratories. We do a lot of modeling work, detailed process analysis and activity-based costing work. And what we find in these specialist laboratories, these specialist functions, that staff have to spend a lot of their time on activities that do not directly relate to generation of results, throughput of tests. This doesn't mean it's not value-added activities. I think the quality, the maintenance, the training are all very necessary. But I think it does show us that if we don't focus our consolidation efforts on the lower volume, more specialist work, and if we don't start impacting this 42% of effort that is generally taken up by our most senior and our most experienced staff, that we're not going to achieve the targets we've set ourselves. Next number is 3.1. Especially last year, unfortunately, pathology IT was in the news too much. That's because some of them still run versions of LIMS systems that was around when Windows 3.1 was released. Now, I think in a world where we update our computer equipment every 2 years and where it feels like software is updated every 2 days, you can't imagine that there's still organizations that process in excess probably of 20 million samples or 20 million tests using software that this antiquated. And I think it just highlights the risk that we sit with and why there's such a desperate need for investment. And this is a big number. It's a number we've worked with NHSI in trying to understand what the likely investment is required just to update not just LIMS systems, but IT connectivity across England's healthcare system. And I think what's important about this number is we don't just need IT for quality of service improvement. We don't just need IT for better service delivery, but we also need IT to deliver better efficiency. We need to find a way of funding this other than relying on capital from nowhere. And here's just one example of where we might find that. So I used the data that was submitted for 16-17, and and I try to understand what percentage of work is still being requested on paper. I took that and then calculated or made the assumption that any paper request will take 1 minute more than an electronic request. And this is work we have validated in some of the time studies we've done. Now, if you just take all of the paper requests and you add up all of those minutes, you end up with 946,000 minutes of unnecessary time being spent to the laboratory just acquisitioning paper requests. Now, to put that in some financial terms, I did the calculation. I'm going to check my figures. If we assume 80% productivity of a pre-analytical staff member at that number of minutes, it relates to, I think, roughly £16 million saving. So 10% of our total IT investment we can achieve just by getting our GPs and our hospitals to adopt electronic requesting. And this tends to be in areas where they already have the systems. Most GPs have the ability to do electronic requesting. Most hospitals have the ability to do it. Also, that 16 million, that's just from requesting. We're not looking at reporting yet. We're not looking at the impact of errors, the management of errors, at the ability to demand manage. I think earlier today we heard from Robert the impact of laboratories using paper and how difficult it makes it to really communicate effectively with it. I now want to move away maybe from our pathology experience and talk a bit more about some other models and some other technologies we're seeing in the market and how those might impact the way that we consolidate pathology. In the last Christmas season, 70% of Amazon's orders were placed on mobile phones. And yet we're having conversations about web applications to deliver results or email communication. We should probably, if we start looking at IT systems, not try and get everybody up to the average, but much rather focus on leapfrogging what the average is and finding new ways to communicate. I was just sitting in the audience today, and I think everybody here looked at their phone at least once, but we're all able to continue our work and continue our day-to-day responsibilities or meet our day-to-day responsibilities because the way that we communicate and the way that we work has changed. And I think pathology needs to catch up to that as well. The other interesting Amazon number was 16. Now that's the number of distribution centers that Amazon has across the UK. From those 16 centers last year, they delivered, let me get the number, 175 million packages. Okay, individual packages delivered to the person's door. To give you a bit of context, we know from last year's data there was 9,400 GP surgeries across the UK. With that many distribution centers and 9,400 GP surgeries, we could do 50 pickups per GP surgery per day. Okay, that's an environment where mostly we argue whether we should do 1 or 2. So in terms of consolidation, the impact of good logistics and the opportunities of bringing more work in from a wider area, Amazon has proven it's definitely not impossible. Next thing I want to talk about a bit is convenience. How our view of convenience changed over the past 16 years is the example I've got here. So 16 years ago, and maybe less than that, 5 or 10 years ago, our concept of convenience when we go grocery shopping was to go to a Tesco Extra that has everything we can possibly need for the week, and we'd buy everything at once because that was convenient. However, in the last year, what we've seen, there's been a 370% rise in the number of convenience stores. These are the places where you buy your bread, your milk, your butter, bottle of wine, couple of beers, whereas the supermarkets have grown much, much slower. Where there were 1,000 more supermarkets across the UK 16 years ago, that ratio is now flipped. There's now 1,000 more convenience stores than supermarkets. And this goes even further. Those of you that are from the UK will know Ocado. I personally use it often. We now want the majority of our groceries delivered to my door. And all I ask of them is predictability. I don't care that it comes here tomorrow or that it arrives on Tuesday. I care that it arrives on Tuesday between 8 and 9. So my view of convenience has changed. The way I interact with my service providers changed. It comes back to, I think, something that was discussed on a number of occasions today around what our customers expect. How do they perceive value? And what is the service that they want? Supermarkets are changing, and I think pathology can really look at how we use that thinking to interact differently with our customers and offer them a different, maybe more appropriate service. And then the last number links to that, 78%. I'm an Amazon Prime customer. I do it because I like Top Gear or Grand Tour, what it's called these days. So that's one of the reasons I buy it. But 78%, so the vast majority of people sign up to Amazon Prime, which costs roughly $100 or £90 in the UK, just for that 2-day delivery. So just the convenience of having your delivery that little bit quicker. Interestingly, less than 2% of products on Amazon is available on Prime, but that's a different story. I think what this really gives us is the idea that there are opportunities for different funding models or different cost models within pathology. Currently, the price you get and the service you get is the same, but what are the options for changing behaviors by allowing certain customers access to maybe a cheaper service? We know from the data that we collected, from the studies that we do, that doing a high volume of tests over a longer period of time allows you much better efficiency, so your cost per test, and I know we've had the conversation about cost per test today, but your cost per test is lower than if you had to allow for that, all that extra capacity to do rapid response laboratory type work. So how are we looking at the way that we cost and how that influences behavior? So in conclusion, I think what I just wanted to highlight are 5 of the main, drivers or the options or models that we can look at adopting for consolidation in England. The first is, yes, there is the need for better networking and stronger collaboration between trusts. The next one is the UK is different, and England is different in the way that our consultants service the laboratory and service the healthcare service. So the consultant interaction is critical, and we need to design a system that fits that constraint. Modern IT infrastructure will act as a catalyst, but it needs to be a catalyst for short-term change, short-term gains, and improved efficiency. Convenience has become a key value-added factor, and the way that we look at convenience has changed. We need to adapt for that. And then finally, innovative funding models and innovative delivery models could shift the cost-saving conversation that we have in pathology. Thank you very much.